Good evening, everyone. Thank you so much for joining us. And I must say, I'm quite pleased to be sitting at home tonight and not travelling across Sydney to the Lifehouse tonight. So I'm really pleased to be here. Also, really very keen to learn a lot more about cancer survivorship, because this is something, I guess, when I first started my career was not even a thing. So it's a great thing that we can be actually dealing with so many people who have actually survived cancers. So our first speaker tonight is going to be really interesting. So this is Associate Professor Trevor Tahala-Burgess, who is going to speak to us on sexual intimacy after cancer. And he's really well placed to speak about this because he's both a gynaecological cancer surgeon at the Lifehouse, but also has done breast surgery work over in America, so putting him in a really perfect place to be able to help a lot of our women survivors of cancer. Thank you, Trevor. Thank you so much.
Thank you, Margot, and thank you everybody for joining us this evening. Indeed, it is a pleasure to be with you tonight, and I'll be talking today about sex and how that matters even after a diagnosis of cancer, and maybe starting a conversation about how we can enhance intimacy for women after a cancer diagnosis. Now, before I start, my slides are not moving along, so let me see if for some reason they're not moving. There we go. I do have some disclaimers, and the first is that I am not a sexual health counselor or a physiotherapist or a couples counselor. As Margot said, I am a gynecological oncologist, trained in the United States, and in the United States I also did a second fellowship in breast cancer surgery. And I learned quite quickly that there was really a need to try to focus on sexual health after cancer. And that's why I've actually started a clinic here at the Chris O'Brien Lifehouse, where we try to address some of those issues surrounding sexuality and intimacy. So in terms of human sexuality, not surprisingly, this is a fundamental way in which we can share intimacy or experience physical closeness. And particularly after cancer, this can include, but it really is not limited to sexual function or to actual coitus. And particularly for women, I feel it is linked to roles in relationship within families, work, and society. So when I am actually assessing women with regards to sexuality and intimacy, I try to keep that at the back of my mind. There are multiple barriers to communication about sexuality. Some of them come from our own sort of concerns, biases, taboos, but also from patients. And it is very common that patients will have sexual complaints, but don't bring them up to medical attention. In one study, at least, more than 50% of women experienced at least one sexual problem, and yet in that study, only 19% have sought medical advice. And when those conversations do occur, often they focus primarily on functional status, and rarely do they focus on mood, quality of life, or relationship issues. So again, I think those are some issues that we need to keep in mind when we're discussing sexuality and intimacy. I think it's very important that we not expect that cancer patients will bring these concerns up to us. If they do, wonderful, but many patients really are not comfortable doing this, and they may actually possess inaccurate beliefs about sexuality as they relate to their cancer diagnosis or within the context of cancer treatment. So some things such as, if he doesn't bring it up, it must not be important. Or maybe I don't want to seem disrespectful. He's focusing so hard on just trying to cure my cancer. Or maybe just at that point in time, it just seems to be too much information. Some women might even be concerned about how that a sexual act may impact them and whether they will hurt themselves. So I think, again, it's important that we open up a conversation, because very often cancer patients will not bring it up to us. And yet studies do show that it is a very big priority for cancer patients. There's a growing recognition that sexuality is an important component of cancer care, and particularly survivorship care. And in one study back in 2010 of inpatient cancer patients here in New South Wales, 40% of those patients felt that they were not receiving enough information about possible changes in sexual activity. So it is important for us to bring those conversations to the forefront. Now, how are we doing? Well, unfortunately, the fact that we recognize the importance of sexuality and intimacy has not really often translated into concrete actions. And one survey that I participated in by Doreen Wiggins on gynaecologists in New England showed that the majority of us, myself included, of gynaecologists in New England felt that discussing sexuality was important, but less than 50% took an even limited sexual history. Most of the time, and I say excuse, the rationale was that there was not enough time. But I suspect that in many cases it was more a matter of just concern and maybe not wanting to open up a Pandora's box if you don't really know how to address those issues. Interestingly enough, there was no difference among female or male gynaecologists in that survey. Unless you think that you are immune to this, in that same survey of those patients' primary care providers, 60% of those healthcare professionals report that they have never or rarely addressed sexual dysfunction, and more than 50% actually admitted that they were unlikely to initiate a conversation. So we're really not doing as good a job, I think, as we could be doing when we address sexual health issues. Now, when should we consider addressing sexual function? Some people will actually state that the ideal situation would be to do this at the beginning of treatment. And I put ideal sort of as a quotation mark and highlight it in red, because I'm not sure that actually at the beginning of that initial consultation for cancer is the best time to start having that conversation about sexuality. Cancer care is, I should say sexual health in the context of cancer care is not really easily standardized. Treatment can vary according to tumor site, prognosis, the type of treatment, patient age, and current sexual function. So your sexual health that ensues from that treatment is going to be quite variable. And I also worry that we might be providing too much information, I put that in quotation marks, at the time when a woman is really trying to just wrap her head around a cancer diagnosis and worried about the possibility of not surviving that cancer. Having said that, I do believe that a little bit of anticipatory guidance is very key, and it's a key element of education. We can anticipate some of the side effects from some of our treatment, whether it's surgery or chemotherapy or radiation. And while a lot of these side effects may not be avoidable, talking about it and beginning a conversation, I think, does allow a woman a sense of control. And I think more importantly, it can set the stage for future conversations. So if we feel comfortable having that discussion, then hopefully patients will feel more comfortable at a later date asking questions about how they might be able to manage the side effects of that treatment. So how common is sexual dysfunction? Well, one survey of Australian women found that 70% of women experience sexual difficulties in the year before the survey occurred. So it really is very common, and it can really impact women with any type of cancer. In my field with gynecological cancers, the overall prevalence is probably in the range of 50 to 60%, according to several surveys. And probably the majority of women complain about dyspareunia. Breast cancer, however, is also extremely commonly associated with sexual dysfunction, overall rates of 35 to 75%, and decreased libido is a major component of that element of sexual dysfunction. But anorectal cancers, particularly those women who have either a low anterior resection or are having radiation therapy due to anal cancers, have a very high incidence of dyspareunia, and even women with allogeneic transplants have a high risk of graft versus host disease. So it really can affect almost any single type of cancer. I have to say that in my clinic, the majority of the women that I see are younger premenopausal women with breast cancer, followed by gynecological cancers. But I have a significant number of women also who I see with anal cancers and sexual dysfunction as a result of that. Specifically in terms of sexual dysfunction in gynecological cancers, not surprisingly, it'll vary according to tumor type. Anatomical changes can occur with surgery. Most women, in my experience, with a simple hysterectomy for endometrial cancer generally don't complain of too much sexual dysfunction that I can attribute to that surgery. Having said that, women who have cervical cancers and require a more extended hysterectomy, or what we call a radical hysterectomy, can have a significant impact. It can impair sexual function by damaging the neurological, the nerves that sort of innervate the bladder and the rectum. It can often cause a foreshortened vagina, particularly if it's coupled with radiation therapy. And nerve damage can impair bladder and bowel function. In our cohort of women with vulvectomies and vaginectomies, not surprisingly, these women will often suffer increased pain and decreased sensation. And then there's also the hormonal changes that can result, particularly those women who undergo menopause as a result of their treatment, altered bowel and bladder function, either from surgery or radiation. But then we also have sometimes functional limitations, so treatment-related fatigue, particularly in those women who have gynecological cancers requiring chemotherapy with neuropathy, things of that nature, or women who've had significantly extended lymph node dissections resulting in lymphedema. And I think, again, it's important not to limit ourselves only to the functional domain, but also identify and recognize that psychosocial issues are very important, particularly in women with gynecological cancers. In terms of women with breast cancer surgery, it's interesting that while we might not really think that there's a direct link to sexual dysfunction with breast cancer surgery, certainly sexual health in general is severely or significantly impacted, I should say, by breast cancer surgery. I've just highlighted two studies, one by Perz et al. And the other by Engel. They basically showed the same thing. And these were in women who had early breast cancer, so presumably women who had a relatively good prognosis. And what these studies showed was that post-operatively sexual function was worse compared to baseline. And interestingly enough, it was desire, arousal, and orgasmic difficulties that were increased after a mastectomy when compared to controls. And I found that somewhat counterintuitive initially, given that you might not expect those kind of functional outcomes as a result of a mastectomy. And again, Engel et al. Found that similar results. And they found that mastectomy reported more disruption and lower scores in body image and sexual domains. So I think, again, looking at and thinking about sexual health on a broader scale is really important. And it is, I guess it highlights the what I like to think of when I'm talking to women, that a lot of women, these were young, early, these were women with early breast cancer, again, relatively good prognosis, who probably a couple years after their treatment looked, for all intents and purposes, as if they were cancer survivors, and they probably were cancer survivors, but still the impact of their treatment on their sexual health was significant. And I think a lot of this probably centered around body imaging and sensation, lack of sensation sometimes after surgery. Interestingly enough, there's actually very conflicting data regarding the benefit of breast reconstructive surgery regarding sexual health. Chemotherapy, not surprising, can also affect sexual function, particularly in those women who are young, premenopausal, where chemotherapy, particularly with breast cancer patients, can precipitate menopause. This can then subsequently lead to impacts in terms of vaginal health, with subsequent effects on libido. And unfortunately, a lot of these sexual sequelae may not revert naturally. In one cross-sectional study of over 500 women, approximately 2/3 of those women had received chemotherapy. That study found that chemotherapy was associated with acute unmet sexual needs, and that those effects persisted despite the chemotherapy having been completed for more than 3 years. Okay, so a lot of these probably relate to the menopausal effects from chemotherapy. And then radiation therapy, both at the level of the breast, but also in terms of pelvic radiation, can have a significant impact. And I think this is one area where I do try to take a more proactive stance with these patients, particularly with women who are getting pelvic radiation therapy for a malignancy where there is a strong likelihood of them developing vaginal foreshortening or vaginal stenosis. So breast radiation can cause local skin thickening, contractures, changes in textures, and it can result in chronic pain or affect body image, which can subsequently result in sexual health problems. But pelvic RT are changes that can last well beyond the time where radiation occurs and when radiation is completed. They say, and a lot of people will say, that radiation is the gift that keeps on giving in terms of sexual health. And there's a significant risk of vaginal fibrosis causing stenosis in women, particularly women who have radiation treatment for anal cancers. The toxicity is variable. The incidence of vaginal obstruction is quite variable, but it can range up to 88% in some studies. And very importantly, this process does not always produce symptoms. So women will say, well, I'm doing fine with the treatment, I'm feeling okay. But unless you actually examine women, you will often not identify that stenosis. And while studies have not really looked at trying to prevent vaginal stenosis prospectively and the potential benefit of that in terms of sexual health, I've certainly seen a handful of women, at least 5 women, who have had radiation treatment for anal cancers, have had full, complete vaginal stenosis obstruction that precludes them completely from having any kind of vaginal intercourse and would require a major vaginal reconstruction to allow them to do that. So I actually have an agreement with most of the radiation oncologists that are treating patients with anal cancer that I will see them prior to starting the radiation to try to address this issue, make sure that they're using vaginal dilators, make sure that we address any hormonal issues, and that make sure we address any other HPV-related changes to the rest of the vaginal or the genital tract, so that we can try to minimize these changes. And then finally, this will link a little bit into part of my other conversation later on about hormone replacement therapy. Endocrine therapy, particularly obviously with women who have had breast cancer, can have a very, very significant negative impact on sexual health. And I have to say that in my clinic, most of the patients that I see are women who have been on some form of anti-hormonal treatment and as a result have sexual dysfunction. Most of the studies do suggest that aromatase inhibitors have a greater impact than tamoxifen does, but they do seem to have somewhat non-overlapping side effects. In the Morales survey of over 180 women, they found that both of these medications increased incidence and severity of hot flushes, and whereas aromatase inhibitors increase dyspareunia, tamoxifen seemed to have a worsening sexual interest and a worsening effect on libido. And not surprisingly, younger women were more likely to experience this toxicity. Shover et al.'s study looked at 129 women, and shockingly to me, 93%, when they actually underwent a objective female sexual function index score, 93% of them basically classified as having had some form of sexual dysfunction. And a quarter of women actually reported discontinuation, full discontinuation of sexual relations as a result of treatment. So I think this is a really big opportunity for us to identify these women and try to address this. It's not clear if that sexual dysfunction is permanent or if it improves or whether we can actually impact it. I like to believe we can, but it certainly highlights the importance of addressing this in a proactive manner. So with that said, I'm going to move a little bit to, well, what can I do? What can we do? I think the first thing that I try to assess, and I think is important, and certainly I think you as primary health care providers, is that it is critical to assess intimacy. Because even in the absence of a physical and sexual relationship, physical intimacy is important, and it's very highly valued by both patients and their partners, not surprisingly. And this was underscored by work by Perz et al. They did a survey of over 40 patients, or about 40 patients, their partners, and their healthcare providers. And what they found was that healthcare providers, again, often viewed sexual health concerns within that physical domain. Are you able to have sexual relations? Are you not able to have sexual relations? Whereas patients and their partners really emphasize intimacy as being important. Not to say that actual intercourse wasn't important, but that sometimes intimacy, even in the absence of sexual relations and coitus, was important. And I think, again, this is an area where intimacy, or the lack thereof, and the inability to establish intimacy may actually indicate an underlying issue in a relationship. And it may be an area where either a therapist or a couples therapist may be called upon. And I try to address this by seeing patients in my clinic individually at first, and I try not to have them come in with their partners so that I can try to get a better sense of whether intimacy is an issue, and whether I think that that may be something that would be of value, sometimes couples therapy or something along those lines. Because I find that sometimes a lot of my patients or clients would really feel a bit uncomfortable about having that conversation with their partner present. So I usually ask them to come in for the first consultation alone so that I can try to address this. Once we've sort of focused on intimacy, then I think it's important to set some realistic goals. And these really need to be determined by the patient. So you need to ask. I feel very comfortable asking intimate sexual questions, but if you don't feel comfortable, then obviously you either become comfortable or refer them to somebody that does feel more comfortable. But the goals may be different, and they may be different for a patient, and they may be different for a partner. So it really is important to try to address this. They also may differ from one person to the next. I think it's important not to assume that it's about having actual intercourse. Again, it may be about trying to address a decrease in libido. It may be simply about trying to decrease dyspareunia. It may be actually that they are having sexual relations and it's actually relatively comfortable, but they haven't been able to orgasm. So having those kinds of questions and very pointed questions will really then ultimately they help me at least address those more directly. Having said all of that, I do think that it is important to set, I hate to say it, but appropriate expectations, and that sexual relations may actually not be as they were before. And we often in cancer talk about this new normal. Well, I think that falls within the realm of sexual health as well. Some patients actually don't have a partner, and they're maybe concerned about the future. So again, trying to address that proactively is important. And then finally, in terms of assessment and setting goals, it is important to assess a patient's commitment, because some of these some of the treatment that I recommend, or some of the steps that I recommend, may actually take time, and they don't sort of lead to an improvement in terms of the sexual health immediately. So it can take quite some time, and sometimes trying to tease out what is most important at that time is the way to go. Now, dyspareunia is probably the most common sexual complaint that I see in my clinic. I'd say probably 3/4 of women will describe significant sexual pain during intercourse. Obviously, it's important for me to do a vulvar assessment, make sure there's no focal lesions or any sort of significant atrophy, or trying to identify if it's atrophy or vaginismus, things of that nature. But the good thing is that dyspareunia, if it is effectively managed, and studies show this, and it certainly seems to be the case in the clinic, I think it's one of the most treatable sexual dysfunction. So when I see a patient with this, I try to encourage them and try to reassure them that over time, I think that we can address this effectively. But it is important to address it effectively, because if it becomes severe enough, it can actually then have secondary side effects. It can preclude vaginal intercourse, and it can subsequently result in what I call secondary vaginismus, with anxiety resulting in just a significant hypertonus at the level of the perineum that just simply doesn't allow a woman to relax and to enjoy sex. So I do think it's important not to focus on intercourse with partners initially, and then once we get to the point where that is something that is possible, and where maybe pain is a little bit better controlled, they can gradually introduce vaginal intercourse. Now, vulvovaginal atrophy is the most common etiology that I see, as you're all aware, largely as a result of hypoestrogenism, and that will lead me into the conversation about HRT. But again, it can certainly exacerbate anxiety about sexual function, and it can result in that secondary vaginismus. So I think it's important to look at vaginal health broadly, and I certainly think that that's something, it's quite surprising to me sometimes how just a few little comments and a few little clues to women will really help maximize their vaginal health and really improve their sexual health quite substantially. Now, vaginal moisturizers and Replens one are actually have been tried and true. They don't do the trick all the time, but they do help. In numerous studies, they've actually shown a reduction in vaginal pH, and enhanced vaginal maturation, improved vaginal dryness, and decreased dyspareunia scores. Now, one thing that is interesting is many women come in and they say that they've been using Replens as a lubricant, or they've been using Replens during sex and it's really not helping. Replens is not a lubricant, and it shouldn't take the place of a lubricant. So it's something that would be obviously used in conjunction with a lubricant. In terms of lubricants, I also often spend time talking to patients about the proper use of lubricants, and I recommend it strongly. Even women who say that, oh, they don't feel that that's an issue, I do think that it is important because many of these women, particularly women who have vulvovaginal atrophy, will have some element of loss of vaginal rugae, and breaking down the friction with the lubricant is really going to help them. Water or silicone base, that's going to be up to the patient's preference, but I have found that a lot of women prefer water-based lubricants and use those primarily. It's much easier to wash. They don't find that there's that much of a residue. But some women, particularly women who have significant atrophy and also are postmenopausal, a silicone-based lubricant is helpful. So for those of you that are in the Inner West, and I have no other interest in that store, but Max Black as a adult shop is particularly helpful. I think they're very, very knowledgeable, and a lot of patients really receive very good counseling with regards to lubricants. They have a wide variety, and I think it's a lot more comfortable for patients to go to a place like Max Black than go to the local chemist to try several lubricants. The only thing that would be of concern would be to avoid silicone, often if you're using a silicone sexual toy, such as a vibrator or a dildo. And I generally recommend avoidance of petroleum-based lubricants, as it can affect vaginal, or it can increase the risk of vaginal infections. I put topical anesthetics because there are some patients for whom topical anesthetics might be helpful, particularly those patients with vestibular type pain. In the study by Ghosh et al., they did find that aqueous lidocaine did seem to decrease pain scores and didn't have any side effects on partners. And in their study, they did show that it improved sexual penetration and allowed women to resume penetrative intercourse. But I say that with a caveat because I did recommend it to a patient who unfortunately had a significant pain subsequently once the anesthetic wore off. So I do think that it is something that can be used in a particular type of patient, particularly those patients who have very sort of hyperesthesia of the perineum, but I don't recommend it for all women. And then sort of the last part that I'd like to spend a bit more time on is the use of HRT, because that comes up a lot in my conversations with patients. As you are all aware, HRT use, particularly with breast cancer patients, is extremely controversial. And interestingly enough, early studies suggested that HRT use actually didn't increase the risk of recurrence, and it seemed to decrease the risk of recurrence. In a large meta-analysis published in 2001 of 8 studies over 3,700 women with a follow-up of 5 years, they found in that study that HRT decreased recurrence rates by almost 50% with a relative risk of 0.6. That led to 2 randomized controlled trials on the use of HRT in patients with breast cancer. And both of those trials actually yielded opposing results. And I think this is where the controversy lies. In the HABITS trial, they looked at 434 women with early stage breast cancer. And at the interim analysis, that study showed an increased relative risk of recurrence after 2 years with a hazard ratio of 3.3. As a result of that, the HABITS trial was discontinued and patients were taken off HRT. And the Stockholm trial that was running concurrently was also discontinued as a result of that trial. The Stockholm trial, on the other hand, was a smaller study of 378 women. And when they looked at the results of that study, they actually found no difference in risk of recurrence at 4 years of survival. When those studies were looked at subsequently, the HABITS trial and the Stockholm trial, 10 years out, in the HABITS trial, the increased risk persisted, whereas in the Stockholm trial, the results were unchanged. There was no increased risk of recurrence within the Stockholm trial. Now, the patients were somewhat different in the Stockholm trial. They had lower rates of combination HRT, slightly less progesterone use, higher rates of tamoxifen, fewer node-positive patients compared to the HABITS trial. So they weren't completely comparable, but it does highlight the fact that the data for, and this is systemic HRT, in the setting of women who are estrogen receptor positive breast cancers is really quite controversial and not completely clear. Having said that, I am not recommending HRT, systemic HRT for women, but I have to say there is one woman that I have from my clinic who had such significant hot flushes that she was actually suicidal as a result of that. And with the sort of agreement of her medical oncologist, we proceeded to a very low dose HRT use and transitioned to tamoxifen in hopes of trying to minimize the risk of estrogen use. This is systemic treatment. Vaginal HRT, I feel a lot more comfortable prescribing. Most studies show that there's very limited systemic absorption, although I will recognize that some studies have demonstrated an increase in systemic levels of estrogen. There's no randomized controlled trials in this setting, but in one very large retrospective cohort, they looked at women who had had breast cancer, and they tried to assess whether these women had received a vaginal estrogen script, and then looked at the risk of recurrence relative to that prescription. And what they showed was that there was really no difference in recurrence. And similar observational studies have found no increased risk. Now, most of these studies are retrospective or significantly underpowered, but overwhelmingly, the data that I have read showed that, particularly with the very low dose estrogen suppositories that we now have available, there does not seem to be an increased risk of recurrence. Having said all of that, I do think that obviously minimizing risk is important, and I would generally go through the process of recommending for patients the use of moisturizers, lubricants, and things of that nature prior to resorting to the use of HRT. Just one slide on HRT use in breast cancer mutation carriers without a personal history of breast cancer. We don't really know what the long-term risks are, but what is important is that the data that we have for the Women's Health Initiative study is not really representative of women who are having risk-reducing surgeries in their 40s for a BRCA mutation. And in the trial by Revick et al. Of just under 500 women who had known BRCA mutations, they looked at 155 women with a risk-reducing BSO that had used HRT for a maximum of just over 3.5 years. And what they found in that study was that the risk-reducing surgery decreased the risk of breast cancer, and that the use of HRT in those women with a decreased risk of breast cancer, that short-term HRT did not alter that breast cancer risk. So it does appear to be safe in the short term. And so what does that mean? Most of the time, the recommendations I give is that you use HRT for 3 to 5 years, or maybe as long as it would be to reach menopause, but with the plan not to use it long term. And then finally, beyond medications, well, this is something that I discuss all the time with the patients, use of vaginal dilators or dildos. Certainly in those patients who have some sort of pelvic floor muscle response or hypertonus, I think that while there's no randomized data, I think there are enough sort of retrospective cohort studies that show that in these women, the use of a vaginal dilator can be helpful, and particularly in the context of a sort of multimodality treatment. The Overcome trial was a very, very small study, but it looked at the use of pelvic floor exercises, olive oil, and a polycarbophil vaginal moisturizer. And while there was no control arm, that study did show that there was improvement in dyspareunia scores, sexual function, and quality of life. And this is something that I have to say I have seen in patients that come through the Sexuality clinic, where that multimodality treatment actually does work. And so sometimes the use of a vaginal dilator or even a referral to a pelvic floor physiotherapist can be particularly helpful. Decreased libido is probably the one thing that I have very little answers for you. Testosterone has been used a lot, and there's always that question, is testosterone? I think decreased libido is very complex. I find it very difficult to treat. There have been a couple of studies suggesting that there may be some benefit. It's phase 1, phase 2 studies that it does improve dyspareunia. I know that there are a number of studies even here in Australia currently in progress. In a trial of transdermal testosterone versus placebo, they didn't see any improvement in sexual function. And so while it may play a role, there's currently no good evidence that it works long term. And there are certainly concerns regarding safety, and there's no specific formulation really that's been approved for women. So I don't typically prescribe it, and the only time that I've ever prescribed it has been with the benefit of consultation with an endocrinologist. And then finally, again, just to highlight again that this sexual health goes often beyond the functional aspect of sex and intercourse. Psychological issues clearly are very important, and they significantly impact body image and relationships. I think it's important to screen for and address depression and anxiety, and how we do that in a way that it allows us to still maintain, some sort of conversation with patients is always a challenge, because time is of the essence often in these meetings. But cancer can certainly result in a shift in relationship, where partners shift into a caregiver role, and there can often be concerns that are expressed by patients about whether that alteration in sexual function can lead to dissatisfaction in their partner, or even to a loss of relationship. And this is one of the issues that I try to address in that initial consultation when I'm seeing a patient on her own. Fortunately, overall, most studies show that most relationships will survive cancer diagnosis, and they're actually strengthened by that experience. So I try to reassure patients that is generally something that will that the relationship will generally survive if it is a strong relationship to begin with. So I'm going to conclude here just by saying that in Australia we've got more than 500,000 people living with cancer. For female cancer survivors, gynecological issues are a major concern, and many of them will impact sexual function. I think we're not doing as good a job as we could, and so there's a lot of work that we should be doing, both in terms of screening, education, diagnosis, and management. The good thing is that many of the more common concerns, I think, can be addressed. Some of the more difficult ones, such as decreased libido, unfortunately, are still difficult to treat. So I think with that in mind, I'm going to address questions, and maybe Margot, you can ask. I think they were going to be chatting if there were any questions.
That's right. Trevor, that was an amazingly comprehensive coverage of this area, so that was extraordinary. Thank you so much. And I guess the main messages I got from that is that we need to ask, don't we, and not to
Absolutely.
be frightened. Because there is, I guess, some of the fear may come from not really knowing what we can offer women, but it sounds like there's an incredible broad number of things that we can offer. So that was fantastic. We actually, are there any questions coming through? I don't think actually we've got any questions. I think you've floored us all. I think you've covered the whole thing. I just wanted to ask a little bit more about Mona Lisa, because I've had a couple of patients who have had that treatment. What's your perspective on that one?
I actually very cheekily took out a couple slides that I had about the Mona Lisa. I have a lot of second thoughts or sort of thoughts about Mona Lisa. I think that it has been put forth as this panacea for basically everything from atrophy to bladder dysfunction to all sorts of things, sexual dysfunction. And I am concerned. I've had a couple of patients that I've tried it on. I actually have offered it to patients, and I do offer it at times. But I think that I'd say that in my experience, most patients don't need it, and it's quite expensive. So I think that having a conversation first and trying to go addressing it in a stepwise manner is probably more important than just sort of saying, okay, well, here's the panacea, take the Mona Lisa, and that's all you need. So my concern always is that there's a sexual health, particularly in women, in my mind, really encompasses so much more than just that physical discomfort. And so by looking and just focusing on the Mona Lisa, we don't address those issues. But I think that there are some women for whom that they may benefit from it, and I've had some patients who have benefited from it. So I guess I'm not sure I've answered your question all that clearly, but I'm just worried that we sort of, we're telling women it's all about pain and atrophy, and I think that sexual health is a much more broad and complicated and complex conversation that we need to have.
I think, speaking as a woman, that's absolutely right, Trevor. I think it is way more complex than all physical. So that's been fantastic. So I really appreciate that. As I said, it was very comprehensive. So thank you so much. And I think you're heading off home now. So thank you very much. Okay, good night, Trevor.
Okay, good night.
Good night. I'd like to introduce our next speaker, which is going to be really interesting as well. So I'd like to introduce Associate Professor Judith Lacey. She's going to be presenting on living well with cancer and survivorship, which obviously is going to be really interesting, particularly because she's a head of supportive care and integrative oncology. So you have to explain to us all what that actually encompasses. But I think it also does cover things such as integrative oncology, medical cannabis, and supportive care. So welcome, Judith. I'm sure you've got a lot to teach us.
Can you hear me?
I can see your screen as well.
Oh, that's great. Now I'll just find my screen so that I can get my talk up and make sure I've got the right one. So you can see
that's good. That's it. Yep.
So thank you very much. I'm sorry if I'm looking a bit shabby. It's been a long day of talking to people. I really appreciate listening to Trevor talk about sexual health, because it's so important for us to talk about this topic with our patients, and it's often really hard for many of us, even after many years of practice in medicine, to still feel comfortable talking about sex and sexuality with our patients. So what I'm going to do is, and I'll fill you in on all those definitions soon, but what I am keen to try and cover in this talk is, firstly, what are the most common concerns of cancer patients during cancer therapy? What are the main concerns of cancer patients post-therapy? And what are the main concerns with this growing population of cancer patients who actually remain on long-term disease controlling therapy like immunotherapy, targeted agents, and have their disease controlled but still on therapy? And how are we creating systems to improve patient outcomes and well-being with this growing complex population of people living with cancer? Because we know that people are living longer with cancer, and Margot and I studied medicine in the 80s as well. And when I studied medicine, the cancer survival rate was less than 50%. And I went on to actually work in general practice for many years, and then re-specialised in palliative care. And as I realised that people were living longer with cancer, we know now 7 out of 10 Australians will survive for at least 5 years after a cancer diagnosis, that we actually had to really put some time into not just looking after people who are dying with cancer, but this large group of people who are living longer with cancer, with some cancer survival rates now up in the 90s. So we know that the mortality rate's changing for different cancer types, and then we also know there are disparities in selected populations, particularly the remote, the Indigenous population with a 10-year gap still in mortality, and low socioeconomic groups. The other thing when I'm talking about this changing cancer landscape is that we have new therapies, and there are new therapies all the time. And so getting your head around the new therapies, the toxicity of each of these therapies, it's actually a full-time Sunday afternoon job, but a full-time job to really stay in touch. We've got immunotherapies, targeted therapies, new hormone therapies, combined therapies, personalised cancer care, genomic testing, improved surgical interventions, and there's a lot more. And so we really need to stay on top of what are the side effects of all these new therapies and how do we manage them proactively. And so over the years, a group of us have been thinking quite a bit, and these are the thoughts that come to mind when I think about how do we keep people living longer with cancer and what our key challenges are. And these are challenges for you in general practice who are working with these patients. And the question is, how do we keep people well during therapy, knowing that their cancer therapy may continue for a prolonged period of time? What do we know about the therapy and the side effects of therapy and these new side effects of therapy, and how to best keep them well? What's the best evidence to support interventions that may manage these side effects? How do we care for the growing population of people living after cancer, the survivorship group, and I'll talk more about that. And how do we keep people living well in this space of uncertainty of living longer with cancer? What's the impact on society if we don't actively engage cancer survivors in programs to improve and maintain their well-being? How do we best deliver these services, and where are they delivered? Should these be delivered in a specialised cancer service? Should they be delivered through primary care and family medicine general practice? What's the benefit of timely integrative medicine and good supportive care, and how do we evaluate the benefits of the interventions in order to get funding to continue the programs and create sustainable models of care? So a lot of questions. And so a lot of us are asking these questions, and there are a few new organisations that are developing that I'm involved in, and really looking at how we best support people who are living longer with cancer and living with cancer. So a few of these organisations are the Multinational Association of Supportive Cancer Care, or MASC, with a mission to promote optimal supportive care for all people around the world who are experiencing cancer, its treatment, or its long-term effects. The Society of Integrative Oncology, which is now a global society, and I'm on the leadership group, and the mission is to advance evidence-based comprehensive integrative healthcare to improve the lives of people affected by cancer. And people like us at Lifehouse in the Living Room and other comprehensive cancer services that are developing these wellness programs to enhance the integration of evidence-based supportive and complementary therapies into this holistic supportive care of all cancer patients. We also have a responsibility, but also our aim is to support people from the time of diagnosis, from cancer detection through diagnosis, treatment, follow-up, and into end of life or survivorship. You need a multidisciplinary care team, and you also, I believe, need a toolbox that not only includes our standard therapies, but also looks slightly outside of the box. And rather than some of the integrative therapies and complementary therapies sitting outside of the system, there's a growing movement to actually bring them in and bring them alongside of the more traditional medicine practices. Not as in traditional medicine, but as in Western medicine. So I thought I'd give a few examples of change and what we could do. And I'll take example of actually 2 cancers, because I made the talk a little bit shorter. And the first is stage 4 melanoma. We all know that people with stage 4 melanoma, this is a growing population of patients with advanced cancer, are living longer thanks to immunotherapy. And so you look at this graph up here, and you can see that for many years, and this is obviously an interest of mine, and we've done some research in this space of how best to support this population. The people with stage 4 melanoma, we'd give them chemotherapy, and you may have seen some of your patients get vaccine therapy, and we were looking at what we could do to improve outcomes for people with stage 4 melanoma. We weren't getting anywhere until a few years ago when we realized how beneficial immunotherapy could be. And if you look at curves with various immunotherapy agents, those that are responders, which are anywhere between 90% and 50% of patients who were responders continued to live for a very prolonged period of time, this flatlining with a diagnosis of a stage 4 cancer, with a 5-year survival improving for responders that was durable in over 73% of patients. So that's pretty exciting. So we asked, how do people live with this uncertainty when offered these new therapies, and how do you support their physical, their psychological, and their spiritual well-being? But also, what do you need to put into place to help people like these melanoma patients to stay active, live well, return to work, and manage the side effects of immunotherapy, these new drugs? Another group of patients who are living longer are people with stage 4 lung cancer. We know that people with lung cancer often have symptom clusters of breathlessness, fatigue, anorexia, cachexia, anxiety, depression, and breathlessness. But we also know that there are some patients with stage 4 lung cancers, you'll see in this top group, and it's not as dramatic a response, unfortunately, as the melanoma patients, who if they are responders to immunotherapy, also have this prolonged survival. And same with some of the targeted agents for people with certain mutations. We're seeing patients who are living longer. So now we have 2 populations, and we have more populations. These are just 2 examples of people who have previously had who had, terminal illness. When I went through medical school in the 80s, these people were dying. We thought, well, what's the point of even starting treatment for lung cancer patients? They're going to die within 6 months. And now we're seeing people living for years with a diagnosis of stage 4 lung cancer. This is really exciting. So how do you keep these people living well, and are they survivors? So let's look at some definitions. And the first definition is supportive care. And this is the definition from the Multinational Association of Supportive Care. That supportive care in cancer is the prevention and management of the adverse effects of cancer and its treatment. And this includes management of the physical, the psychological symptoms, the side effects across the continuum of cancer experience, from diagnosis through anti-cancer treatment to the post-treatment care. So enhancing rehabilitation, secondary cancer prevention, survivorship, and end-of-life care. In other words, alleviating symptoms and complications of cancer, reducing or preventing toxicities of treatment, supporting communication with patients about their disease and prognosis, allowing patients to tolerate and benefit from active treatment more easily, eases emotional burden of patients and caregivers, and helps cancer survivors and psychological and social symptoms. So that's the brief that I'm given when I am seeing a cancer patient for a survivorship or a supportive care consultation. So what's integrative oncology and how does this differ? And integrative oncology is a relatively new field, and this definition was developed and with a group of key representatives of the Society of Integrative Oncology and published in NCI monographs in November 2017. Integrative oncology is patient-centered, evidence-informed field of medicine that utilises mind and body practices, natural products, and or lifestyle modifications from different traditions alongside conventional cancer treatments. So it aims to optimise health, quality of life and clinical outcomes across the cancer care continuum and empower people to prevent cancer, become active participants before, during and beyond cancer treatment. So very similar to the aims of integrative medicine within general practice, but very specifically to integrative oncology. So I see supportive care as the umbrella term, which includes integrative oncology. And so then we get confused because then you look at what are the definitions of survivorship. And I don't love the term survivorship. I like the term supportive care and holistic supportive care, enhanced supportive care much better. And when you'll see this definition, and this is from the National Cancer Institute definition of survivorship, you'll understand why these are all overlapping and sometimes difficult, as Margot pointed out, to really say, you know, what is that? You know, and actually explain what it is. So in cancer, survivorship focuses on the health and well-being of a person with cancer from the time of diagnosis until the end of life. So very similar to the definition of supportive care, including the physical, mental, emotional, social and financial effects of cancer that begin at diagnosis and continue throughout treatment and beyond. What is in addition, what is specific to survivorship is that survivorship experiences also include issues related to follow-up care, late effects of treatment, cancer recurrence, second cancers and quality of life. And so we bundle it all under the big umbrella of supportive care, which includes survivorship. In America, they've talked about survivorship care plans as being very important. Sorry, I'm getting a lot of messages on my computer keeps beeping. And so COSA, the Clinical Oncology of Society of Australia, tried to put this into a flow diagram to help guide people through this terrain of what's survivorship, what's supportive care, and how we best support patients. And I quite like this diagram in that it looks at what we do at diagnosis. And at diagnosis, on your far left, we talk about health literacy, educating people about the long-term effects and the short-term effects of their treatment and the potential impact it may have on their well-being. So we've heard about sexual function, and talking about that up front is incredibly important, but also the fatigue related to treatment, the peripheral neuropathy and so on. We try and support people into a period where we start planning for the future at the end of primary treatment and look at risk stratification and specific rehabilitation needs, looking at the whole person. And then according to the risks of the patient, look at follow-up care. So if someone has a low risk, how much support does that person need? If someone has moderate risk with complex needs such as persisting cognitive fog, persisting peripheral neuropathy, ongoing sexual dysfunction, ongoing issues related to chronic pain or chronic symptoms, what intervention is required and what professionals are required in that multidisciplinary team and approach. And finally, those people with high risk or complex survivorship issues, looking at how we best integrate and develop a care plan for those people. You'll hear a lot about survivorship care plans. And finally, looking at who best is to provide that care. when it's provided by the hospital, when it's specialist-led, and that interaction, which I think we're still getting our heads around and really need to work on that connection with general practitioners and education such as this to talk about the symptoms and symptom management in primary care-led survivorship programs. So there's an article, and this is from the article in the Australian Journal of General Practice that Janet Vardy and others published last year. It's a 2-page article, and it's very nicely set out. And in one of the boxes, they talked about the key elements that you need in managing, looking at survivorship. So healthcare teams should implement a systematic approach to enhance coordinated care. Stratified pathways should exist. There should be support looking at wellness, healthy lifestyles, primary and secondary intervention, and late-term effects and comorbidities. There should be a transition to follow-up care, particularly back to the general practitioner with a clear survivorship care plan, which I think we're starting more to get our heads around, and we're working on that in our department. And survivors require equitable access to services. So it doesn't help if we don't really advocate for equitable access to all of the resources that have been shown to be of benefit. So let me take you back to what we're doing, because I guess from our experience, it's sometimes easier for me to talk about how I see survivorship and best supportive care. And I ideally see that we should be intervening and seeing people from the time of diagnosis, particularly on their symptoms and concerns. The majority of the patients that we see in our service, and our service is myself as a doctor, I have another doctor commencing with me, a nurse, care coordinator, oncology specialists in massage, acupuncture, yoga, exercise physiologists, nutritionists, psycho-oncology, and reflexology, and I'm sure I've missed somebody out, but we work as a multidisciplinary team. And from the time of diagnosis, then we primarily see people during disease-modifying therapy when they start getting symptoms and in trouble, and we're looking at a proactive screening process. But also 50% of our patients are either living with advanced disease or in the survivorship space, or both, and looking at how we best develop strategies and interventions at each key time point throughout treatment. Our model is, I'm a bit obsessive about making sure that everybody uses screening tools, that we discuss everybody in our weekly multidisciplinary team, and as a collective we develop a care plan that best manages the person's symptoms and concerns based on evidence-informed interventions. So let's look at the common side effects, and I have to say I've got absolutely no view of the webinar, and so please just yell to me if I'm watching the time, but if I need to stop. So the common symptoms experienced by cancer patients, what else can we offer? So we know that the most common symptoms that our patients experience, and we did a survey and evaluated all the patients referred to our service in a short period of time between 2017 and 2018, and this correlates with the publications from other services, that the most common symptoms that people present with are fatigue, anxiety, fear of recurrence, sleep disturbances. For breast cancer patients, it's hot flushes and chemo-induced peripheral neuropathy. Head and neck cancer patients, xerostomia. The cognitive effects I can talk about for an hour, but the impact in this cognitive fog of breast cancer or other cancer diagnosis, the cancer treatment itself and hormone therapy is quite significant, and helping people return to work and to activity when they've got a cluster of symptoms of fatigue, poor sleep, dreadful hot flushes, anxiety and cognitive fog is actually quite a challenge, and takes a holistic multidisciplinary approach to care. But that's probably the most common presentation for example, breast and ovarian cancer patients. And so these clusters of symptoms are common, and in my consultation, as with others working in the field of supportive care and integrative oncology, and as I said, it's quite a new field, it's this comprehensive assessment that many of you will do in your general practice. The advantage to me is that I'm within the hospital system, I'm within the electronic medical records, I know exactly what chemotherapy they're having, what side effects they're having, what their bloods are, what other medications they're having, what their plan of care is, and I've got that all in front of me. And so I look at that. And I provide a whole person care approach, so it's a patient-tailored strategy, really attuned to that biopsychosocial model of care. And then you address the key concerns and the goals of care with a real focus on starting to make the lifestyle changes now, implement exercise from the time of diagnosis, and address the specific symptoms so that people have a proactive approach to their future and empowering them into survivorship from the time of diagnosis on. And it's incredibly rewarding medicine. So let's take the example of a patient with ovarian cancer. So often I see quite a few patients with ovarian cancer from anywhere from stage 3 and stage 4 cancer. Often they may have toxicity related to the surgery itself. They may be dealing with the uncertainty and the fear related to the diagnosis and fear of recurrence, may have had treatment which has shown no recurrence, or on a break and on surveillance, which is quite common. Many people who have had ovarian cancer or living with ovarian cancer will have bowel symptoms, and diet are really important to tease out. We've talked about sexual dysfunction, and I omitted that from my list here. But managing common treatment-related toxicities of neuropathy, fatigue, sleep disturbances, nausea, bowels, arthralgia, myalgia is the bread and butter of my work. Managing symptoms of local and metastatic disease, new toxicities from new therapies. But the most important thing is, how do you develop a proactive approach to this survivorship and surveillance and empower the patients, empower them to move forward and look at how I can live the best life possible every day. And so the National Comprehensive Cancer Network have written quite a few guidelines. And I will take the most common symptom, cancer-related fatigue, as an example of what these guidelines look like and what we do as a holistic supportive care and survivorship consultation. So first is look at the disease, and on your left you'll see the history you need to take. And on the right, some of the other concerns that can be reversible that you need to address in order to reduce fatigue. And the next is interventions for patients on active treatment, and looking at the non-pharmacological interventions. So once you've established someone is not on a medication that's made them fatigued, don't have anemia, don't have severe B12 deficiency, etc., you then look at what you could do that's non-pharmacological. And the level of evidence is quite high for physical activity. Now, to tell somebody that's absolutely exhausted to exercise is quite hard. And if you look here, there's also a high level of evidence for recommending massage therapy for people who are fatigued. So I often say, well, come and have a massage, and then we'll book you in a week or so to the exercise physiologist and develop a personalised program. Yoga is also an intervention that has a high level of evidence to improve fatigue, as well as managing sleep disturbances. And when we look at mindfulness in the post-treatment group, then that's also a high level evidence to improve sleep disturbances and fatigue, as is CBT. And finally, other therapies such as acupuncture and reflexology for CIPN, looking at the evidence to support these therapies. And so we spend a lot of time looking at what we can do proactively to improve outcomes for patients. And finally, I'll finish with this slide, and this is a slide from the book, Anti-Cancer Living. And Lorenzo Cohen and his, it's actually his wife, who's Alison Jeffries, wrote a book called Anti-Cancer Living, looking at how to live well with cancer and beyond cancer, and talked about this mix of 6, and I've adapted it for the purposes of this slide. But we speak to people in survivorship about making sure they have good support and good love, and if they don't have that supportive environment, how with support groups and other ways we can assist people in having a very close and good emotional support. The second is making sure that their stress is well managed and people put into action a stress management plan, whether it's our online mindfulness program, yoga, counselling, or their own personal stress management program, but making sure that we actually talk about it with our patients in the consultation. Sleep and sleep hygiene and ways to improve sleep is fascinating, and we hope to be running a webinar on sleep in the near future, because it's quite a complex issue and really has a home in the integrative oncology space. Exercise from the time of diagnosis, 150 minutes of moderate exercise a week to strength classes, and finally diet. And I think many of you will speak to your patients a lot about diet, what's a fad diet, what isn't a fad diet, reducing sugars, reducing dairy, increasing protein, clean eating, high cruciferous vegetables, and so on. And really talking about a healthy, proactive Mediterranean diet that improves outcomes. And finally, making sure that the environment is as healthy as possible, both the emotional environment and the physical environment. And it's the synergy between all of these that keep people well and in balance. And so referring to us, we're here to help you, and I think you'll all get copies of our slides, but most importantly, we really want to make sure, as per the Clinical Oncology Society of Australia guidelines, that every patient has a personalised exercise program. We have a proactive lymphedema program. So people that are at risk of developing lymphedema, early intervention gives better outcomes, and so we have a proactive lymphedema assessment and program for people who are at risk of developing lymphedema, who have early lymphedema, to improve outcomes. We're starting a survivorship clinic, hopefully in the next few months. And with COVID, we've developed a whole lot of online programs for you to have a look at that are free and on our website, including some yoga sessions. We've got an online mindfulness program, and we've just received our ethics approval for our yoga for lymphedema and mindfulness programs, which will be coming soon. And of course, educating our
Thank you so much, Judith. Again, it's such a comprehensive presentation. I think you've covered just about everything I could imagine. And I certainly do understand the difference now between supportive therapy and survivorship, and what a broad job integrative oncologists do. So thank you so much, and thank you for staying back late tonight to talk to us. So we're going to move on to our third speaker. We don't actually have any questions for you, Judith, so we're going to move on to our third speaker, who is Dr. Robin Sayer, who's going to help us understand how to actually refer into the Lifehouse, particularly for women with gynaecological cancers. So Dr. Robin is a gynaecological oncologist who specialises in gynaecological cancer surgery at the Chris O'Brien Lifehouse. So welcome, Robin.
Okay, thank you very much. Hopefully everyone can hear me.
Yes, we can.
Now see me.
See your slides.
Good. So my talk, very intimidating to follow those two excellent talks, but I'm hoping mine is a nice, easy, wrap up the session, practical information of, okay, now you've found a patient that you think needs gynae-oncology, and how do you who do we select for to come to Lifehouse, and how do you actually get them in with us in a timely fashion and properly dealt with. So I'm just going to go through all of that information. I don't think my talk is as long as the other talks, which this time I know is probably a good thing. Oops, just trying to get my slides to move. There we go. Okay, so again, first thing I'll address is why refer to Lifehouse. There are a bunch of options of places to choose throughout Sydney and New South Wales, but what makes Lifehouse potentially different, and who to refer to a gynaecologist, whether it's here or another service. What about Lifehouse do we have as a specialised service that other places may not have? And then how do you practically refer someone to Lifehouse? So this is just the obligatory slide of the state of gynecologic cancer in Australia from data from last year that shows that the vast majority of patients that we see are uterine cancers or endometrial cancers, with almost half of our patients having that diagnosis. And that is what we see across Australia. And this, unfortunately, pink wedge of pie is only increasing as obesity increases as a problem in Australia. The second largest group of patients we see are ovarian cancer patients. About a third of them come to a tertiary centre for their surgery. And then the smaller wedges that we see are cervical cancer and vagina and vulva cancer. Hopefully these wedges of pie will decrease with time as we see the effect of the HPV vaccine in the coming decade. So to answer the question of why would you refer to us, you first need to know who we are and how we operate as a group. So there are 5 of us as gynaecologists at Lifehouse. The current acting head of the department is Dr. Rhonda Farrell, who's the first woman in the picture on the screen. Then there is Selvin Pather, Sam Sadie, myself, and Trevor, who you met earlier. We're all RANZCOG and CGO certified. Trevor and myself actually trained in America. Sam trained in the UK, and Selvin and Rhonda are the locals. So there are also 3 gynaecology fellows on the team that are with us for several years at a time, and so they're a consistent name that you can often call on when you're trying to get in touch with someone to refer a patient. And then there's a rotating series of senior registrars and an SRMO that rotate on a 3-monthly basis. There's 2 CNCs, Belinda Zaloni and Shannon Phillip, and then there's patient navigators and our department secretary, Maria Santos. So when you refer a patient to Lifehouse, you're not just referring to one of us as a gynaecologist, you're actually referring to an entire system, which was touched upon by Judith Lacey earlier. When you refer a woman, it's not just about the cancer surgery. Oftentimes there isn't even a component of surgery in the woman's care. And there's lots of people involved, maybe not from the onset, but eventually in most of our patients' care. Radiologists and pathologists are instrumental, both at our MDT meetings and obviously in the tests that we order throughout the patient's stay. There's the allied health team that includes occupational therapists, dietitians, psychologists, really strong service in psychology here, particularly focused on dealing with the cancer-associated issues, but also the non-issues that do come up under times of stress. Social work, CNC, there's a lot of overlap between the CNC and the social work. There's again clinical trials and data managers if we have someone that is a candidate for a clinical trial, and then of course radiation oncologists and medical oncologists. And all of this as well involves the critical person that actually gets the woman through the door, which is all of you guys, the general practitioner, and that's plus or minus the involvement of a general gynecologist on the way through the door. And I'll tell you the set of circumstances where you can skip the general gynecologist and come right to us so that we can expedite the patient's care. So that graph is basically recreated every Friday at Lifehouse. We have our gynecologic oncology MDT. Starts at noon and it goes for at least 3 hours, often a lot longer. And we discuss a lot of cases. We rely very heavily on our MDT because we very much believe in multidisciplinary care. And the only way to do that is to actually involve everyone in the conversation, not only from the outset, but also throughout the lifetime of the patient's care with us. So all new cancer cases and suspected cancer cases get reviewed at Lifehouse. We look at their outside imaging, whatever outside biopsies or results they may have, and make sure that everyone agrees with the plan that we've laid out for the patient when we've met them. And sometimes they'll suggest something we haven't thought about, or an ancillary test where the radiologist has picked up something on the outside scan that wasn't reported by the outside radiologist. Anyone that has surgery and is either a cancer or a pre-cancer gets discussed at the MDT. Had surgery at Lifehouse, that is, and also for that matter at outside facilities. I travel down to Canberra once a fortnight. I have been for 10 years, so cases that I may do the surgery down in Canberra, I get everything sent up to Sydney and reviewed and discussed. And similarly, Rhonda Farrell, who does some private work at Prince of Wales and Randwick, does the same thing for her cancer cases. And then there's also a set of complex dysplasia cases that we talk about weekly, and this may be discordant results between the referring cytology and what we've found on colposcopy and biopsies, or it may be someone with a very complex anatomy or medical history that would make the idea of an excisional procedure quite challenging. When we talk about the patient, we review all of their clinical history, our physical exam findings, we review the imaging, we review the pathology, we send out for the slides, and we talk about the entire case as a whole and come up with a consensus recommendation. And essentially almost everyone that's was on that spoke wheel graph that I showed previously attends the MDT meetings. The pathologist and the radiologist are obviously critical. There's the 5 of us, gynaecologists, medical oncologists, radiation oncologists, genetic counsellors, the fellows and registrars, the CNC, and occasionally there'll be outside doctors that are involved, like a radiation oncologist from Canberra, for example, that's referred a patient that wants to be involved in the discussion because they're the ones that will be ultimately providing whatever radiation the patient might need afterwards. And we involve them on a sort of case-by-case basis if they're interested, and just for the review of their case, and then they go back to clinic or whatever they're doing for that day. So who to refer to Lifehouse? So obviously anyone with a woman with a diagnosis of gynecological cancer or suspected gynecological cancer. There is a category of women at high risk for gynecological cancer, abnormal cervical screening tests per the Australian guidelines. And I'll go through each of these because some are clear cut and some have grey zones. So the bottom line with anyone diagnosed with gynecological cancer, so this may be, for example, your cervical screening test comes back saying squamous cell carcinoma or adenocarcinoma or endometrial cancer, or if you've done a biopsy of a vulvar lesion that shows a squamous cell cancer, then my bottom line for this would be to skip the general gynecologist. The answer is there, so send them straight to us so that we can expedite the process and get a move on treating them. The next group is a little bit more of a grey zone because there are sort of subtleties to all of these things that I've listed below. So any woman suspected of gynecological cancer. So for endometrial cancer, obviously it's peri and postmenopausal bleeding, particularly with a thickened endometrium on ultrasound, or any persistent irregular vaginal bleeding on someone older than 45 years old. And obviously there's lots of non-cancer reasons for bleeding. And we're happy to review whatever referral gets sent and decide, are we the best person for that patient, or are they better served going to a general gynecologist potentially first and then seeing us if necessary. The next common referral is concern for an ovarian cancer. So complex masses on ultrasound or any sort of imaging over the age of 45, obviously ascites, with or without an ovarian mass, suggestion of malignancy on imaging in basically women of any age. We will at least review it and decide, is this someone that needs to come and see us, or are they better off with a general gynaecologist first? And then family history of ovarian and breast cancer, and for that matter, endometrial cancer or colon cancer. There are, I'll go through in a little bit, the common hereditary cancer syndromes that we are often involved with. And then for cervix, any abnormal appearing cervix, regardless of what the cervical screening test is showing, we're happy to look at and reassure whether this is something to be concerned and perform biopsies to make sure that we're not missing anything. And then recurrent or persistent postcoital bleeding is also another one that, just regardless of what the cervical screening test is showing, deserves a gynaecologist to have a look and make sure that we're not missing something. And for the vulvar and vaginal cancers, they can have a variety of appearances on examination. They can be ulcerative, like a non-healing wound, exophytic and warty, or even a pigmented lesion. You can get melanomas of the vulva and of the vagina and cervix, for that matter. So if you see an unusual looking pigmented lesion, even though you might think, well, that's never seen sunlight, it can actually be a melanoma and definitely needs to be referred to us directly, with or without a biopsy. And then I'll just mention Bartholin's cyst mass in a postmenopausal woman. Obviously, Bartholin's cysts and abscesses are common, but if you have a, let's say, postmenopausal woman who never in her life has had a problem with a Bartholin's abscess, and she rocks up at the age of 55 with this new mass on the vulva, that's someone to refer, because that's a cardinal sign of potentially a Bartholin's gland cancer. And then there's a group of women that are predisposed to gynecological cancer or have a high risk, and these are the most common hereditary cancer syndromes that we see are obviously BRCA1 and 2 and Lynch syndrome. Lynch syndrome, while it's most well known for being associated with colon cancer, women's risk of endometrial cancer is just as high as their risk of colon cancer if they have this syndrome. And oftentimes, in fact 50% of the time, endometrial cancer is the cardinal cancer that they get if they have Lynch syndrome. And then there are some lesser known ones like Cowden syndrome, Lee-Fraumeni syndrome, and Peutz-Jeghers syndrome. We see them very well, maybe a couple of these a year, but definitely Lynch and BRCA are quite commonly seen and managed, and we counsel them about when is the appropriate time, or what are their options in terms of prophylaxis, whether that's surgery or medical, and what is the appropriate time in their life to move towards those steps, and then we will perform the surgeries if necessary. And then another big group of patients that we see, we're particularly high volume when it comes to colposcopies and treatment of cervical dysplasia here at Lifehouse. So according to the Australian Cervical Screening Guidelines, there's a list of patients that you would be well aware of that should be referred for colposcopy, and they're listed below. So HPV 16 and or 18, just as a one-off event, regardless of their cytology. If you have 2 annual HPV non-16-18s in a row, they get referred. Possible high grade or a high grade, regardless of the HPV result. Any glandular or possible glandular abnormality. DES exposed women are actually recommended to see a gynaecologist or someone particularly aware of DES and clear cell cancer of the cervix and vagina, because these women actually need annual colposcopies for their whole life of both their cervix and vagina. And then when the referral comes to Lifehouse, when it's a abnormal cervical screening test, it gets triaged into risk categories by very set criteria. So a high risk, for example, a possible high grade or a high grade, will be triaged to be seen within 4 weeks, and the lower risk ones, for example, the HPV non-16-18 ×2 with non-high grade histology, will get triaged to be seen within 12 weeks. And we stick really strictly to those criteria. The other thing I wanted to mention is some specialised services that have already been touched on today by the other speakers that we have at Lifehouse. We work really closely with the other subspecialty surgeons at Lifehouse and across the road at RPA. With pelvic exenterations and pelvic peritonectomies and the radical ovarian cancer debulking surgeries, or if we have a patient that needs a portion of their ureter removed as part of an operation for a pelvic mass or bowel surgery, we always involve those other specialties because they're here and there's plenty of them. I think there's 8 colorectal surgeons at Lifehouse, so you can barely throw a stick without hitting one. So why not involve someone that has the expertise to help with the bowel portion of the surgery? And then we also do a lot of minimal invasive surgery here, like advanced laparoscopy with sentinel nodes for most of our endometrial cancers for the appropriate candidates, and also robotic surgery. We have a gestational trophoblastic disease clinic that is not only a face-to-face clinic but also a virtual one, because we do pull a lot of gestational trophoblastic disease patients from all over New South Wales. Trevor is actually the one, Trevor along with Shannon Phillip, the CNC, manage that clinic because there are lots of HCGs to keep an eye on and chase down. And then obviously Trevor, who spoke earlier, runs a sexual intimacy clinic, and you can see how good he is at discussing and managing women with these particular problems, whether they have a gynae cancer or another cancer treatment that's led to their issues. There is a rapid access outpatient hysteroscopy clinic that Sam Sadie runs for patients that need to be fast-tracked into a hysteroscopy. There's also a survivorship support that's run out of the living room, which Judith Lacey is heavily involved in that, as is Belinda Zaloni, our CNC. And then obviously lots of clinical trials happen at Lifehouse. And if we have the trial open here for the patient, then we obviously get them involved, but we also have our heads around what other trials are available, not only in New South Wales but around Australia, if there's a particular case where a trial fits the person. We've got no problem involving other facilities. And so now the I guess most important question is, how do you get someone referred to Lifehouse? So if it's urgent, for example, it's 5 o'clock on a Friday and someone has rocked up to the GP clinic with what looks like a triplet pregnancy in their abdomen, you can always call us through Hospital Switch and ask for the gynaecology consultant on call. We, the 5 of us, rotate a weekly schedule. So the one gynaecologist will be on for a week, and then we rotate it through the list. And so that's one way to get an urgent, end of the day Friday or even a weekend phone call sorted. If you're unsure and you don't know whether it's appropriate person to send, then by all means call us and we can go over it on the phone with you and decide whether we're the best person to see, or if we're not, then who would we recommend. And I've just listed, I didn't put everyone's details here because I didn't have a chance to actually ask them whether they'd be okay with it, but I listed, this is just my personal mobile number, as well as the phone number for my, what would you call her? She's more than a secretary. She's like a admin extraordinaire, Tally, who, if you've got any questions or want to ask me something directly, then by all means, feel free to call me or Tally, and you'll get a copy of these slides, so you'll have these numbers for future use if you need them. The probably most common way that people send referrals when there's not really any direct conversations that need to happen, and there's just the usual amount of urgency as there would be for someone with cancer, would be to send through the Lifehouse website. So there's 2 options. There's you can import a referral template for gynaecology, which if you go to the website and you'll find a list of PDFs that have the referral templates for the different subspecialties, and gynaecology is one of them. And if you've got best practice or medical director software, you can auto-populate the patient details and then simply attach the results, like an ultrasound report or whatever, and then upload everything directly via the HealthLink system. Otherwise, if you don't have access to those programs, you can just fill out a referral template, just print it out, handwrite it in, and either fax or email it to us at as directed on the website and as listed here. The third mechanism, if you're finding that you're not getting through to who you need to get to and you're getting frustrated, or if it's a night or weekend and you really need someone seen, let's say on a Sunday morning, you can call the GP Direct Access Cancer Team. So this is manned by a landline Monday to Friday, and then there's an after hours number, and then also a fax number. And this phone is taken very seriously and is available to anyone that's just feeling like you're not, if you're getting a runaround or something, you can always call them and they will literally walk into the gynaecology department and say, we need to sort this out, and we'll find one of the 5 of us to help fix it. And this is just a copy or a picture of what the referral looks like for the gynaecology. So this is that PDF that you can either hand fill out or type in or whatever, or do online. And I just recommend that people have a look at it and maybe get the more updated version, which is actually not exactly all the way updated, because I noticed Professor Jonathan Carter's still on the list, but it is more updated than it was, because Rhonda and myself joined Lifehouse maybe about, well, I've been at Lifehouse unofficially, but now within the department for almost 2 years now, and Rhonda the same. So you may want to get an updated one, because some people are still, well, lots of people are still sending referrals that they probably printed up 5 years ago, and have just kept in their clinics. So I'd suggest getting a new one, and then it's just a matter of ticking boxes and filling in what's necessary, and then either printing or emailing it, or whatever means you have. And then on the second page of the referral, it does give you a brief idea of, okay, you're sending someone for an abnormal pap smear, can you please provide the smear? That's sort of basic. Or if there's, a pelvic mass, we'll ask for some tumour markers, etc. But again, if you want to expedite the process, you can always call us, and we can say, well, could you please organise a CT scan or an MRI, and that will help us get the patient sorted sooner rather than later. And that's really all I have. So pretty informal one for the last talk, and hopefully we can provide a good service. As you heard from Trevor and Judith Lacey, it's a really holistic, patient-centred place at Lifehouse, mostly because it was designed and built and envisioned by the O'Briens, who really put the patient first in every single aspect. And hopefully your experience with us will show you that that's what Lifehouse is all about. Thank you.
Thank you so much, Rob. And I can actually feel how much you all are on the patient side. That comes across really strongly. I just wanted to quickly check with you that GP Direct Access Care Team, that's for all cancers, not just for gynaecology, isn't it?
Correct, yeah. Any person that is needing something dealt with urgently and they're not feeling like it's getting... So I guess the first person to try to do would be to contact us, or to contact whichever subspecialty directly. But if you find that, maybe someone scrubbed in theatre and not answering their phone, and you're sitting there with the patient right in front of you with a serious situation, or even if you're just feeling like you're not getting to where you need to get to in a timely fashion, or not getting the answers you want, then they're sort of the quality control phone number that you can call, and it won't be someone within the specialty you'll get on the phone. It'll be basically a very high up admin person, and they will track down the people that are trying to be reached, and either them themselves, or if they find out, oh, the reason they're not answering their phone is they're on holidays or something like that, then they'll find the next person on the list that is covering those patients and get you to the right person.
Oh, that's fantastic, Rowan. I'd just like to say that also that the Lifehouse team, the gynaecology team, were fantastic with making sure that everything is in health pathways. So anyone who's not sure how to refer to the Lifehouse, there is all that information in there, and I certainly would recommend using the online health link referrals, because they do all the auto population and make sure that we include all the right pathology and everything. So I definitely recommend them. Anyway, I'd like to thank you very